We shall now go on to our next speaker, Dr. Udhay Kumar, who is a distinguished and a very well-known ophthalmologist from DRR Eye Care and Oculoplasty Hospital, Chennai, and he is going to show us his tip. And some more learning we are going to get from his video. On to you, Dr. Udhay. You need to unmute yourself, Udhay. We can't hear you.
Okay.
I want everybody in the background to mute their videos. You are not heard. Can you increase the volume on your laptop? Maybe you have.
It's at the maximum.
We can hear you, Dr. Udhay. Now we can hear you.
Yeah.
Thank you.
Yeah.
You want us to share your presentation, Dr. Udhay?
Yeah, here it is.
Actually, you'll do it.
Yeah. He'll do it. Yeah.
One minute. 1 minute. From the beginning. Yeah. Okay, this is about a relatively straightforward, simple cataract surgery of a 65-year-old patient where the initial steps of cataract phacoemulsification went uneventful. So as you can see, the Rexis, hydro, phacoemulsification, everything went on very smoothly until the intraocular lens insertion and the IA. So I normally place the IOL under BSS, and here what happened is I didn't increase the side port incision size. So it was really snug. And then what happened was the IOL also didn't go into the bag in one go. So as you can see, the IOL was stuck here, and you can see my left side port. It was not into the anterior chamber as it should be, and it was at the wound edge. And you can see a fluid wave coming from the left side. Before I could react, the entire descemet was detached. You can see that. So then after that, I placed air, made the patient lie down for 15 minutes, and then I thought it is done. But then this is what I saw in first post-op day, where there was no air and the entire diffuse corneal edema, and in ASOCT it showed the entire descemet was detached. So you have various options of either going in and filling with air, C3F8, SF6, either you place the relaxing incisions or wait and watch, and worst case scenario, you have to plan an endothelial keratoplasty. So this is the descemet membrane detachment management protocol. So it's based on that health algorithm, depending on the height, extent, length of the descemet membrane detachment and whether the pupil is involved or not. In my case, because it was almost involving the entire cornea, the pupil was involved. So we decided to take her immediately, and I took her to the OR. So I did a surgical PI to avoid a pupillary block, placed sutures so that the wound is airtight. And then I placed a big air bubble from the opposite side, in the side port from opposite side of descemet membrane detachment. So I checked for wound leak, then removed the speculum, waited for some time. Then I made the patient lie down for an hour in supine position. So to my relief, the cornea was clear next day, and the descemet membrane reattachment was confirmed with ASOCT. The take-home points are: prevention is the best policy. Early detection and treatment is key, preferable during primary surgery itself. Make sure that the anterior chamber is well formed and keep your instruments properly. In this case, the cannula should be kept properly inside the anterior chamber. Thank you.
Thank you very much. I would going to ask questions to Dr. Madhukar and Dr. Nikhil. And Nikhil, definitely. I hope he stays connected. Now, we do know that DM detachment can occur rarely if we are more likely in maybe eyes with endothelial disease or thick arcus senalis and all. It's known theoretically. And also we know the eye is hypertonous. We should inflate the eyeball and then take our instrument in, and the infusion should be on only after the instrument enters the eye. Some of these are preventive measures. But I would want Dr. Madhukar to advise as to which are the cases where you would think of using air alone and which are the cases when you would want to use C3F8 or SF6.
Yeah, if there is the descemet is cleanly detached, means there is a nice big flap which you can put it back, then air will help. But if there is if you have manipulated and the descemet is torn, and then you need to have C3F8 to inject it. But in most cases, if you know it early and then do not manipulate further, air will help in most cases. If it's not helping only, then we have to go for C3F8.
And when are those cases, Dr. Arundhati, you are there? When are those cases would you think of giving a venting incision along with a DM detachment?
Well, actually, as Dr. Madhukar pointed out, I think most of these cases, it suffices with just injecting a bolus of air in the anterior chamber. And only if you find that after 1 hour of lying down, if you find that if the cornea is too taut, then you may take the patient to the slit lamp and give a venting incision there, But often I think on the table, when you push in air, you wait for some time, you just try to dent the cornea with an iris repositor. If it looks sufficiently well-maintained IOP, I think you can get along with these cases.
Dr. Shrikant Sahu, can you comment? Are you there, Dr. Shrikant Sahu? Okay, I would believe that if it is a planar kind of a DM detachment, and if the central cornea is clear, you could actually let it be, and conservatively also you may be able to manage it. But if there is going to be or if it's going to be a hammock like a detachment, then yes, air bubble would do. But if there is DM detachment is in tears and it's hanging, and in those kind of situation, definitely makes sense to use a C3F8 gas or SF6 in those cases. And if there is interface where there is sort of viscoelastic would have further separated the DM, are those cases when you would do a venting incision, so to allow that to escape, because only then the DM is going to get reopposed. Dr. Shrikant Sahu, have you ever seen any situation where the
I agree
DM
with you completely.
No, a late detachment,
Right.
where initially the detachment was not there, but it happened later. Have you all dealt with those kind of situations?
Correct. Yes. So, for me, viscoelastic will be a complete no, because viscoelastic is known to not let the DM attached with the stroma. So that way, ACM, if you start with ACM and give a C3F8 gas, it's good. Sometimes what happens, if you see it, once this gas goes out also, it again rolls down. So there a compression suture through and through will help after the second incision of gas.
Have you heard of any late DM detachment?
Yes, there have been. Yes, there are sometimes there are small detachment which is not goes unmarked in the initial phases, but it comes down after 2 weeks to a month later on.
Okay.